smile on nearly 11 million people till date. What more we can expect in the future with Hyperopia smile already on board. Welcome, Dr. Ryu. Thank you.
Thank you. On behalf of the Korean actors here, I'd like to welcome all of you to Seoul, Korea, and hope to enjoy your stay while we have a wonderful weather during this weekend. So today I'd like to introduce the smile surgery. So the topic I'm going to present to you is the past, present, and future of smile surgery. I have a few financial disclosure to make informed to you. And to start with, from the 1930s through the 1970s, there were 3 big episodes and with the 3 distinguished doctors who made a contribution to the refractive surgery. Dr. Sato from Japan introduced radial cornea cuts, and very well-known Dr. Barker from Colombia introduced the keratoconiosis manual in 1963, and also 1974, Dr. Padrov from Russia were able to introduce a radial keratotomy known as RK to refractive surgery. And there were some challenges and limits that were introduced in the early days, so that the laser got into the role inside of the refractive surgery field. 1980s, we were introduced with the PRK. 1990s, the LASIK were introduced, but still there were some complications and some hurdles that we have to go over, so that the searching for the flapless, minimally invasive alternatives were needed and asked for the doctors, so that the SMILE, small incision lenticular extraction, was in developed process. So that's why we call SMILE surgery the 3rd generation. First one was PRK and LASIK. Second generation, we can categorize as LASIK and femto-LASIK, and third is flapless lenticular surgery called SMILE surgery. We can see the 1996, the Zeiss were able to introduce a concept of the lenticular extraction from the picosecond laser. 2007 were year that the professors Secundo and Blum first performed flex. That's the nomenclature of the SMILE before SMILE. The flex was introduced and first performed to the patient. I was able to meet him in 2019 in his hospital in Marburg. It was very gracious and pleasant gentleman who showed everything to me where he performed the first SMILE surgery. So now the SMILE was approved, and now in US FDA approved, and from the low diameter to high myopes and also mild astigmatism, we can do the SMILE surgery in very wide range. Because the external laser was non-efficient in mid periphery, we need more energy to make a very even distribution energy delivery. You can see femto laser can deliver, regardless of the myopic correction amount, same amount of energy was delivered by the SMILE surgery, where the excimer laser, it corresponds to the amount of myopic correction from 3 diopter 4 joule up to 11.9 joule with the 9 diopter. We have to spend more energy to correct more amount of myopia. From that, we can find some inflammatory changes and also biomarkers related to the inflammation more in the LASIK surgery. And from the beginning and all the data shown from the literature that the smile was at least efficient and successful in early days. Later on, with the long follow-up reports, we were able to find that the smile stability is a little bit better than the LASIK. And that's because we have very complexity reasons. The first one we found that as a clue is that posterior corneal elevation change was less in smile surgery. And also in our own data, we found out that the corneal epithelial thickness change were less in smile surgery. So those are clues that the smile delivered more biomechanical stability compared to our conventional LASIK surgery. So this is our clinics data. For low myopes, now we are having about 75% of patients with the smile surgery, and with the moderate myopia, identical number as 74% now. So smile has very lot of advantages compared to our conventional PRK and LASIK surgery. That's been said already. Where are we now? That's the present. In Korea, we are now able to use 4 or 5 different sets of devices that can deliver KLEX. Size offers Smile and Smile Pro, and Smile Pro has been used for more than 2 years now, and Clear, SmartSight, and Silk as competitors are available in Korea now. I don't need to go to this part because many speakers will speak about what is better with the Visumax 800, but the two distinguished features in the Visumax 800 is oculine and central line, and we were able to publish the first comparison study in Korea between 800 and 500, and you can see the 800 and 500 has a very similar refractive result in between two groups, and the short-term stability and residual astigmatism amount was very identical in both groups. But because of the central line open line, which makes more better saturation, and also the cyclotogen compensation, we were able to find that the striker aberration was less induced in the 800, and also the vertical coma is less. So that beside the refractive indices, the high order could be better with the Visumax 800. Oculine, by then you were manually operating the oculine, but now through the forum we were able to link the IonMaster 700 with the Visumax 800 so that it's now working automatically in Korea setting. So after doing it by automatically, I was curious whether the to either of more of astigmatism patients have better results with the Smile Pro. So we went to the data, and the data showed that the little difference was shown in very early stage of follow, so that the Smile Pro showed better results with the higher degree of astigmatism. So what we are going now, what would be the future of the smile surgery? I know some of you are not okay with the Visumax 800 yet, so because of the regulatory difference, so that the Visumax 800 will be available to you soon. And hopefully, as time passes by, we can have more speeder device that reaches over 2 millihertz pulse frequency even faster than now, and customized nomogram, AI-driven customizing nomogram program It's now available, but will be available to most of us in the near future, and automation and robotics, and also hopefully photography or away from guided, customized lenticle design would be available to us. New indications of hyperopia still not yet, but with the Visumax 800, hyperopia and mixed asthma is now approved, will be approved in future. Enhance the outcome, of course, is obvious, we will find out. And eventually, with the faster recovery and transition from PRK LASIK into SMILE, the SMILE will be eventually converted into SMILE Pro. The SMILE Pro will be dominating the KLEX surgery market for the future. That's my end of my talk. Thank you. We can clearly see that the difference between the manual
For now, you can use
and
this one,
automation
and you just use this.
able to
Now
use
you show
it
the
now,
page, yeah.
so that we can strongly recommend this SMILE Pro even better with the patients over the diaper of oxygen. So I think the centration and occupying is
Thank you very much. I think Professor Sarah's done is great. Thank you.
Thank you. Apologies. So, many of you know that I don't know if it's because I'm American or whatever, but I have no problem with criticizing bad ideas, especially if they're not accurate. And so what I wanted to share today was an analysis, which I've done, of the different KLEX procedures. And because it's becoming more and more frustrating to see how marketing claims, and this is not just KLEX, it's IOLs, it's everything in refractive surgery. It's just so many claims that are not scientifically backed. And so, because this is a Zeiss symposium, and because SMILE is really a Zeiss invention, I'd like to take the opportunity to, like a colleague, I want to give you my interpretation of what is going on in the marketing place, because if you're a Zeiss user, you need to be able to answer some of these questions. And of course, I was very much part of the development of SMILE, but not early, I told you. We know that the earliest lenticle extraction machine was started in 2002, that was the Visumax 500. They released it in 2007 with Flex, but that obviously wasn't, it was a stepping stone, it wasn't what we wanted to do. SMILE had a limited release in 2011, I was one of the people involved. Before this, Rupal Shah, obviously, and Walter Segundo. And then we started the hyperopic studies, first in Nepal in 2012 under my direction, and then in 2013 we published 3 papers on this. And then the first copy to market came out, the copies came out in 2020. And this was the Z8, which was designed to do lens cutting, and the Zimmer Atos, the Schirmed Atos. 2001, we released the second generation device, and you've heard a lot about this, no need to talk about it more. And then Silk from J&J came out, 2023. Let's be clear that in 2024, we had already performed 10 million procedures, of which 9 million were done in Asia, mostly in China and Korea. So these are the devices on the market, and I'm now going to go through my analysis. I'm sorry. That was a mistake, because I was just literally changing a slide before I came up on stage. Okay, that's good. Thanks to the wonders of technology, I'm able to go back to what we need here. Okay, so if we look at the patient interface, the Visumax, as you know, is corneal suction with a curved contact glass, so it's very, very low pressure in the eye. With the Atos, it's actually conjunctival corneal section. It's more peripheral, and it's very high pressure. It's 250 millimeters of mercury. The same, very high pressure with the Zemer, and the same with silk. And let me just point out that the silk is using the same intralase interface, which is this plastic stuff, which with a syringe, with a pump, and it's super basic. And centration is everything in lenticular surgery. And so you can imagine the interesting things that are going to happen when your centration is not verified because you have applanation and the parallax errors that are created by applanation. I just want to go to the Schwinn, and because I just had the experience myself of going under an Atos, and actually with an anesthetic drop in my eye and a speculum, I was coupled to the device. And here's what's interesting. You have to understand that Zeiss is obsessed with patents, and they have a whole department, hundreds of lawyers that patent all day. And one of the patents is that the illumination that we have on the Visumax goes through the contact glass plastic and then gets pipeline illumination inside the cornea. And so what's interesting about how they got around this was by having illumination on the side. And I can tell you that it is big glare sitting under this thing, because they have to illuminate the cornea through all this plastic sideways. And then when you go inside the contact glass, the green light is not focused. So when I was attached to the device, I saw about 4 spread out points of green. And when I was observing the kinks being done, the docking took ages. And they kept on starting and stopping to make sure that it was exactly on the right place. They have 2 stages of docking, soft docking and then hard docking. And it's really quite a lot of work. In terms of the cutting, now we know that the Visumax 800 is the fastest lenticular cutter, but you have to forget about the frequencies because that's got nothing to do with it. It's all to do with spot spacing and spot energy. But obviously the faster the cutting time, the safer the procedure because of suction loss, but also we now know from David Kang's work that the laser tissue interaction is completely different if you go very, very fast. There's no time for the bubbles to expand while the next spots are being laid down. So actually, it makes a huge difference to be able to complete the lenticule faster than slower. Now, the specs that you see on these brochures, they're very misleading. So, for example, some of these companies talk about using much lower energy than the Visumax 800. But that is not actually how it works, because what they're not including is the fact that the numerical aperture of the Visumax optics is so high that there is almost no energy going above and below the impact point. That's very different for these other devices that have a lower numerical aperture, and therefore the energy is dissipated in the z-axis in a much greater area, and therefore there is technically going to be more thermal damage because of that. So why is it that only Zeiss has a wide numerical aperture? Well, the reason is that the optics are so complicated to make this numerical aperture at that infrared wavelength that only 2 companies in the world can make optics with that level of precision. One of them is Zeiss, and one is a company in California. When you look now at what we really should be basing our information on, and that is peer-reviewed literature. Not brochures, not claims, but publications. Things that have been vetted by anonymous competitors who are trying to kill you, and they're trying to make you not publish your paper. So it's a barrier to entry in terms of publications. There is no contest. The Visumax has over 1,200 publications, and I hope that the other companies will have 1,200 publications, but they don't have them yet. And so I want to go through a lot of the claims and show you that it's really unfair of some of the companies and some of the things they're saying. We all know that the optics and the pathway, the 38 kilos of lenses inside the Visumax, the 500 and the 800 are the same. The only difference in the 800 is that scanning mirror technology improved, which is why they were able to use the same laser head at 2,000 kilohertz instead of just 500. But the optics and the laser head are the same. Hyperopia, the lenticle geometry, we talked about it earlier this morning, the large transition zones, and the ability to do very high hyperopic corrections completely safe. So let's go here. So I'm not quoting either magazines, ophthalmology magazines, or brochures. So we're getting a claim here that the advantage of the Atos compared to the other devices is that tracking and cyclotorsion compensation is available with the Atos, but not with the others. Well, that's wrong. What we have from Zimmer is that it offers some advantages. You can move the lenticle to help with the centration after docking. Make sure it's in the right position. Well, I'm sorry, but that's not, John, with all due respect, you don't have to move the lenticle with the Visumax because the docking is done on the vertex of the coaxially fixating eye. So there's no need to move anything. The problem with the Zimmer is that you're blind as you're activating. And then once the treatment starts, you can't see anything. So of course you need to have software moving of the lenticle. But the Visumax doesn't require this. If you can see here just quite simply, as I showed earlier today, the docking and the docking lollipop makes it exceedingly easy to achieve centration on the visual axis with a verification of how far you are. This is less than 100 microns, less than 200. This is 100 microns away from the visual axis. So there's no issue with that, and cyclotorsion is perfectly controlled. With the 500, we also had the same control. The difference is it wasn't software-based. We had to have an image of the eye, and we had to verify that the docking and the suction was applied when the patient was coaxially fixating, which you verify by talking to the patient and asking them. Here is my friends Christian and Nathan in Peru. They're using the same standardized protocol with their 500, getting the same perfect results. Rotation of the contact glass, which Sri Ganesh was one of the first, I think, to start doing this. It works perfectly well because you put your marks and then you put the eye on the marks, and that's end. There's no need for tracking or anything because it's a fixated eye. And as I showed, the results that I get in our clinic are exactly the same between the 500 and the 800. Because the manual processes which we developed for the 500 have just been made easier by automating and using computer assistance. So the docking and the centration control and the iris recognition are just faster ways, more efficient ways, more workflow-related ways of doing the same thing, but the same results. Now, the SmartSight makes some claims. They say that they have, the advantage is no minimum thickness, that the lenticle tapers to nothing in the periphery, and that the overbent cap cuts deeper in the periphery as an advantage. Well, I'm sorry, but none of these are advantages, because the reason why we introduced the minimum thickness is because if you have a lenticle going to 0, then that means that before 0 it's 1 micron, before that it's 2 microns, before that it's 4 microns, before that it's 6 microns. And basically, if you get OBL or any difficulty in that section, you're going to very easily punch through the edge of that lenticle, and it's not going to be a round lenticle. We get this with the Visumax 800 also sometimes. It happens. But you're really going to get it if you have zero tapering, where you have more interaction between the bubbles of each layer, because they're very, very close together. So somehow it's a little bit of a magic trick to say that this is a better thing. Also, we'll talk about the parallelity, the parallel nature of the cap. But you see, when you're cutting in the smart site, you are not looking coaxially. That's why it looks like the thing is decentered. It's not actually decentered. It's just that you're looking at it from the side. And if you look at the periphery of the cap, it's not concentric in this image. Now, if I see that on the Visumax, I know there's been an eye movement, because the cap and the lenticle edges are concentric. So this thing about it not requiring a minimum thickness, it's reducing the lenticle thickness. Well, why is that an advantage? The lenticle thickness is what it is. Also, the minimum thickness produces a reduction in the induction of spherical aberration. And that's a fact, and that happens because of epithelial dynamics. So again, this is not a correct statement. When we actually have evidence to show that minimum thickness is a good thing. Shri also, about 10, 15 years ago, we were talking, and he said to me, I'm using higher minimum thicknesses because I'm separating the interfaces of a -1 lenticle further away, so there's less bubble distortion of the lamellae. And there's now a controlled study where they did standard 10 micron and thicker lenticle minimums in the same myopic population. And they found that the efficacy index was higher if you use more, and there was a statistically significant difference in safety. It was actually better safety if you separated the two interfaces. So if anybody says it's better to not have a minimum, explain these results to me. So again, by the way, it was more accurate as well, which makes sense, because if you distort the first image, the first interface, and then cut through bent lamellae, then the lenticle is not going to be as regular. And so the accuracy is going to possibly suffer. And that's all to do with this idea that the bubbles are being put in, and they start to coalesce. And so if there's time for the bubbles to coalesce, they will distort the lamellae above and below, and then you will make a cut through distorted lamellae, which then becomes an irregular cut. Now that's what we had in the early days of SMILE, when the visual recovery was so slow. And that's when we used to say, SMILE is no good for low myopia. Well, it was because the visual recovery was very slow because of this. But we now have minimum thickness. So the idea that you have a zero thickness is better. I'm sorry. Ooh, what happened? It's interrupted. Okay, my animation didn't work. But anyway, there's no peer-reviewed literature around zero minimum thickness. And there's definite evidence that minimum thickness is better. This is an example. I have the study software on my Visumax 500. So we are able to go down to zero. And I just want to show you the difference between the edge of a 3 micron minimum, and a 30 micron minimum. And I think one image speaks 1,000 words. Double edge sign is actually made much easier. The separation of the upper and lower interfaces at the edge of the lenticle is actually made much easier by having a minimum thickness. Here we're going above the lenticle. And I don't normally operate at this magnification, but this is for the demonstration purposes. We're now clipping and engaging the lower interface, and then we see the double edge sign. You see, and that's because there is a minimum thickness of 10 microns, and it makes it very easy to push essentially against a small little wall to get in under the lenticle. And we know from speaking to our colleagues who use systems that go to zero, that finding the lower edge can be problematic. And you can have a difficult dissection. You can have a situation, even though you have a perfect bubble pattern, because there's variability in maybe the laser energy during the morning, or also between the lamellar packing from individual stromal structures in individual humans. And you can see here that I'm going to struggle a little bit attach the edge. And that's because, well, the laser tissue interaction was different in this eye than the previous patient. And I actually have to compensate for this. So I'm finding that edge. But imagine if there was no minimum thickness and there was no wall to be pushing against. It would be much more difficult. Now, there's something about the overbent. Now, what they mean is that the cap cut is not parallel to the surface of the cornea. And the reason why they can't do that is because that is patented. So the power cut with the Visumax is on the first cut, and the planar cut is on the second cut. Now, this apparently protects against decentrations by not cutting into the epithelium. Well, this is what they mean. What they're thinking is that the epithelium is thicker in the periphery. So if you have a parallel cap, you're going to be closer to the epithelium than if you have a bent cap. This is what they're saying. But if you, excuse me, I know a little bit about epithelium. And if you look at the anatomy of the epithelium, actually the thickest epithelium in our 110 published series in 3 dimensions with 1 micron precision over a 10 millimeter zone was 64 microns. So 64 microns is miles away from the cap. And there's no way that this theory that bending the cap away from the epithelium is of any purpose whatsoever. So again, why are companies making these claims which make no sense? If we do a 135 micron cap and you go 4 standard deviations above that, you're still 53 microns away from the thickest epithelium of the whole population that we studied. Do you understand what I'm saying here? None of this makes sense. Now, the idea that cutting from the center to the periphery is better because if the center is treated first is bonkers. That's exactly how SMILE started. And that is exactly the work that Rupal Shah with Hartmut Vogelsang and Matthias Wartke, they did this work in Bombay. And they discovered that the sequence of cutting actually changes the one-day recovery tremendously. And that in fact, one-day visions are much better if you temporarily separate the interfaces at a minimum. So here's an example. This is a paper published by Rupal Shah, and you can see that the spiral out versus spiral in gave much better results with spiral in, and that's because of this distortion case. So spiral out would be spiral out and then spiral in, right? Now, if you do spiral in first and then spiral out, then the time between the two interfaces, as that quote says, in the most important part of the cornea, that time is minimized. So it's better to do spiral in, spiral out, than spiral out, spiral in. So again, it's as if we're being told things that we're not going to check the logic. We're not going to think about it, and we're just going to take it for granted that this is true. And as you see, the percentage lines lost was much higher if you go spiral out first. Finally, let's look at clear. Again, they're claiming no minimum thickness is an advantage, and that the incisions lead to both planes. That you have one incision that goes up from below, and one incision that's supposedly only going to go up. Well, I'm sorry. I mean, we've all done thousands of SMILE procedures. This is not a problem. Okay, it's not a problem, especially if you have a minimum thickness. So again, claims that are being made that are just not real. When you look at the cutting sequence of the clear device, actually it's pretty weird because they take a photograph of the eye and they freeze it and they make you think that you're looking at the eye while it's being cut. But that is a cartoon. It's not the bubbles. It's a cartoon. In fact, the device is blocking the cornea, and you cannot see the bubbles while they're forming. And in our course, our forefront course, which we teach in London, we're teaching in Bangalore in September, we talk about the importance of examining the bubbles as they're being formed, because it tells you information about black spots, where you might have to dissect more carefully, where you might, it gives you information. It also gives you information as to whether you might want to adjust the energy for the second eye. Well, if you're blind as to the bubble pattern, you're not going to be able to adjust the energy of the second eye in the same way. So again, the advantage to be able to make the guiding tunnels to help less experienced surgeons, well, how many eyes do you do when you're less experienced? I mean, I don't know, 10, 15? This is not an advantage. Sorry, John, I'm quoting you here. But there's no evidence for this to be the case. The double-edged sign, which a novice surgeon can learn, any surgeon with half of dexterity brain can find these edges. Finally, the carp technique, which of course means that it doesn't matter if you go if you go below the lenticle first. It doesn't matter. In fact, when Glenn developed this idea of flipping the instrument forward, the modified sensitive to catch the lenticle off the cap, which has 100% efficacy in grabbing the lenticle off the cap, we started doing smile all the time underneath first. And we did that for 6 months, both of us. And then we presented a paper at the ESCRS showing the outcomes were identical between the two procedures. In fact, there was a non-significant, slightly better recovery on day 1 for the lenticle on the cap. But it wasn't a big difference. So, again, this is not a complication. It doesn't matter if you don't find the lower interface first. It doesn't matter if you go below first. These are not consequential elements. Finally, this idea that, one incision is better because of it. No, it's not. If you read our textbook, take our course, there are 9 reasons why you should make 2 millimeter incisions. So when someone says, I don't do 2 millimeter incisions, I say, well, you have 9 reasons that you're missing the opportunity to take advantage of 2 incisions. Finally, lower energy. Sorry, John, you're all over the place, but they did put you into the literature all over the place, so I'm sorry, it's a consequence to being printed these days. It's like Twitter, when they pull up something from 10 years ago that somebody said, and then they ruin their lives. This is not going to ruin your life, I'm sure. Look, the collateral damage is more with the other systems because of, like I said, the numerical aperture is much, much smaller. And that is what leads to the difference between how much energy is absorbed in the stromal tissue that is not related to cutting. So, again, not a true statement. Finally, when you look at these parameters, because of everything I've said, because of the speed at which the spots are laid in and the laser tissue interaction with the expanding gas bubbles, because of the numerical aperture, these numbers are not comparable. It's apples and oranges. They're not comparable. Now, Nobel, as we saw this morning, they performed a head-to-head study on all the studies, on all the devices, comparing them to LASIK. And as you were shown, the visual recovery, the uncorrected visual acuity, actually ends up being better with LASIK, as we expect. But it's very close to two of the devices are actually lower in terms of visual recovery constantly, and very much lower in the earlier phases of recovery. Now, Marcus Bloom and Kathleen Kühnert, they did one of the very first energy versus smoothness publications with electron microscopy and showed that the lower the energy, the smoother the cut. Your own Korean superstar here, David Kang, he did a fantastic study where he divided the patients into 2 groups, a low energy group and a high energy group. And he found that the average roughness was correlated, and he measured this roughness in different ways. And he actually charted and showed us very much what the bubble pattern progression is, depending on the energy, and keeping the spots spacing and track spacing exactly the same. So you see, the ideal is the lowest at the top, and the one at the bottom right is not ideal. David Donate also was looking at low energy treatments, and he found that there's much better 1 month visions if you use lower energy, and the MTF was better if you use lower energy. So this is not new information, but the Zeiss device is giving lower energy because it has a high numerical aperture. Our textbook has this information that the more energy you use, the more bubbles you're going to get, and the less energy used, the more lenticular regularity you're going to get. But you have to find the happy spot, because the lenticular regularity relates to visual recovery. But if you go too low, then you won't cut. And because there's a standard deviation to the laser energy, and if you go to the plasma level, you may end up subplasma, not cutting. So the whole principle here, David Kang has just had a paper accepted in the Journal of Refractive Surgery, where he shows that if we go to plasma and then click up a little bit from there, you can have it looks like there's no bubbles except the side cuts. And the dissection is reasonable, but the higher order aberrations are much lower than the way that we've been doing SMILE 10 million eyes so far. So he's about to revolutionize the way we do SMILE. The same thing is with the spacing. Obviously, the closer you put the spacing, the more OBL you're going to get. But the closer, you're going to get difficulty dissection because the cutting isn't right. But if you have wide spacing, you're going to get difficulty dissection because it's too far apart. So you have to find that happy middle where the spacing is not too wide, not too tight, to get separation to be even, and of course to minimize suction time, because the closer the spots, the longer the suction time becomes. And so Zeiss actually Andre Nahr worked on this algorithm when he was head of applications, which now means that it's absolutely standardized the way a laser is inserted into a clinic and calibrated. So this is actually, there are, I don't know how many units, there are thousands of Visumaxes in the world, and they've all been installed and calibrated in the same way. Finally, silk. The idea that you have a biconvex lenticle is pretty funny, because even with a parallel cut to the surface, which we have on the SMILE, it is convex, right? So all the lenticles are biconvex, all of them. So it's not even a correct statement. They don't have a unique biconvex. They have increased convexity because they cannot do a parallel cut because they're blocked. And the other thing is, of course, they have this extraordinarily bizarre cutting pattern where you imagine if there's an eye movement during this petal-shaped cutting process, the irregularities could probably be quite severe. Also, this system is showing you a cartoon of the cutting, not the bubbles. So again, we're missing out on the opportunity to examine the bubbles and understand the dissection forces or the areas that we may have to take care of. Oh, the other thing is that okay. So this idea that the posterior and anterior surfaces are more matching and therefore there's better biomechanics is also not quite right. Because indeed, it's true that if you take a lenticle out, the arc length of the cap is longer than the chord length of the bed. It's true. But here's what we do with that. You see, here's the cornea with the cap not distended. We don't irrigate. We take the lenticle out and we go to the slit lamp where we put heavy fluorescein. And then we take the redundant cap and we push it out to the periphery. Like a LASIK procedure, you make sure that the central area is smooth and the redundant tissue is pushed out to the 8 millimeter zone. And what that means is that the visual recovery is faster, and if you do have redundant cap, it's pushed out to the periphery. Here it is, retroillumination, there's the redundant cap out in the periphery. Now we know from, so the idea that you have better biomechanics because there's less discrepancy between surfaces is not true either. Because we know from Professor Zhou's studies, hang on, I don't have the slides. Professor Zhou, there he is, and we know, and Professor Yao, who did the studies, that the number of folds is higher the more myopia you treat, which you expect, but also they decrease with time in SMILE. Whereas if you compare it, they compared it to LASIK, where the number of folds stays the same with time. Now, why is that? It's because with time, the cap actually takes on tensile strength. Somehow the cornea is sort of adjusting itself, and the posterior surface probably models itself a little bit forward, and suddenly there is tension that is taken up by the cap. And his studies prove that the cap is not static over time, and therefore we are not worried about the biomechanical strength of a biconvex with less discrepancy versus what we have in terms of a planar power cut setup which we have now. So again, biconvex and plano-convex. The number of fibers that are cut is exactly the same because it's the thickness of the lenticule that determines how many fibers you're cutting, not whether you're planar or convex. It's the same number of fibers. And we have evidence that SMILE is more biomechanically or less biomechanically insulting than LASIK. We have evidence of that. There are several papers in the literature on this, but none of the other companies that are claiming better biomechanics have any evidence of this. So again, claims without evidence. As you know, our study, which was actually the first model that was published, showed that that SMILE has more tensile strength in theory than LASIK, and it's been shown. So, faster nerve regeneration because of less corneal fibers being cut. Well, again, this is just mumbo jumbo, because the thickness of the lenticule is what determines what fibers are going to be cut. And we have plenty of evidence published that if you make the cap thicker, you will have less cutting of the nerves. So our way of doing SMILE is to avoid cutting into the nerve plexus by making thicker caps, which of course also allows us to do LASIK over SMILE for the enhancement, which is much nicer than a circle or a PRK. And here are all of the dry eye publications after SMILE, and we know that in SMILE, the corneal sensitivity returns very, very quickly. Certainly within about a month, it's almost normal. And it doesn't even go down that much on day one compared to LASIK. So again, we're not cutting too many nerves. So claiming that you're cutting less nerves is like a double insult. Finally, suction loss. And we have a very specific protocol for managing suction loss. And the thing about suction loss is that when you're in the cap, you just put it back on and cut the cap again because it's parallel. Whereas if you have a biconvex lenticule and you get a suction loss, now what? If you don't lock in exactly on axis, you're going to have a little bit of a disaster. Whereas with a plano-convex lens, you can move into a different position and you can finish the cap cut. So there's another reason why biconvex is not better. Anyway, if we go to the peer-reviewed publications and we go to the facts, like our textbook, which is 500 pages with 157 pages of complications which you don't have to have anymore because we're teaching you how to not have them, we are the Mona Lisa. And, we didn't really get Christmas cards from the other companies thanking us for all of the advantages that we've given them in first completely denying that SMILE was a good idea, and Tresby is better, and this, and Leighton, and Couture is better, and this is better. Oh, really? Oh, that's funny, because now you're doing lenticle extraction. So it's all very disingenuous, you know? That's all I wanted to say, and that's my personal opinion, not the opinion of Zeiss. This is my analysis, and I take full responsibility for everything I said. And John and I are good friends, so there's no problem here. Okay, thank you very much.
So I'm going to talk about basically what's the 800, what the 800 laser can offer. As we mentioned previously, not everybody has access to the laser yet. Hopefully it will be available, and mainly due to sort of market restrictions and rollout with the laser system as well. These are my disclosures basically over here. So as you heard from the first speaker, we've seen an evolution of lenticle extraction over the years, where we've gone from a fully flat-based procedure with a flap and the lenticle being created on the left-hand side, and the flap was then basically shipped off from the bed. It's a very old video, I think almost about 16 years ago now, compared to basically doing a small incision lenticle extraction, which was the obviously marketed, basically smart procedure. And, you know, it's been quite remarkable that over the years, you know, you look at the worldwide penetration of SMILE procedure from those early days back in 2011, 2012 to where we are currently now. And the penetration is quite interesting because, of course, you know, we're competing against LASIK. So, you know, it was quite interesting. And, you know, I can tell you one of my first meetings I went to, I talked about lenticle reimplantation, how you can buy, and Dan came to me, "John, does it really work?" I said, "Yeah, you know, it does work and stuff." So, you know, we were one of the early movers basically in this area. And of course, when you have good market penetration, you've got to have some evidence-based guidelines. Because why we're talking about this, I think, this afternoon, about a publication in basically ophthalmology, for which I was a part of, basically looking at basically guidelines with respect to not only pre-operative assessment, but intraoperative complications, and also basically post-operative issues that may face you when you're doing lenticle extraction procedures. And I think this is important to have these guidelines now as we look at KDEX procedures, which will now become more and more prevalent. As you heard previously, of course, SMILE has had an amazing growth rate, increasing up to 10 million procedures, and last year, Zeiss actually credited really for this, for getting 10 million procedures out. But when you look at this as a comparison of the global refractive market, actually this is just the tip of the iceberg. 10 million is nothing compared to basically, you know, over that time period, compared to 5 million procedures that were done basically in 2026. So clearly there's room for expansion for many people who are not doing basic lenticle extraction around the world. And we can see that still the market share of procedures is done with LASIK. Now, over this time period, as basically SMILE has matured, obviously the Visumax laser system has basically matured from the 200 system that we have over here to the 500, and of course then to the Visumax basically 800 to basically do a SMILE Pro. And if you look at this growth curve over here on the left-hand side between 2012, between 4 million procedures all the way up to 9 million procedures, you could beg the question that why should I buy a basic Visumax 800? And Dan actually just spent it in his talk. His results with the 500 are the same as the 800. So why would you invest in an 800 if you can get the same results in the 500? So I get asked this question a lot. Should I just buy a second-hand 500 Visumax laser? Is this going to be even possible? So you can go to the normal sites for basically 5 or 500. You might find it on Amazon, or if you live in Asia, you can try Shopee as well. You might be able to pick up a cheap laser from there. But one of the things is, obviously, when you buy old laser systems, you have to be aware of fakes, and all of you who do internet shopping will know. This is an example of this on the left-hand side over here. I was in New York one time with my sister. This is the Challenger space shuttle Intrepid, and it happened to be in JFK for a show. And on the right-hand side, when I used to go to Russia to do surgery at the Federal Institute, this is the Buran space shuttle, and it's actually in Gorky Park. Now, if you look at them, they look actually quite similar. Okay, on the outskirts itself, they actually look similar. The difference is the shuttle, the NASA shuttle on the left-hand side did 125 mission, and the Buran mission basically did 1. Okay, and that was basically it itself. But you can actually buy it, it's in Baikonur, you can actually buy this. But this one actually is in Gorky Park, and you can see there's a ladder there and stuff, you can go inside, and I tell you that shuttle is not going anywhere. It's completely empty inside as well. So beware of fakes when you're basically looking at buying second-hand lasers. So if we look at the visual acuity outcomes of the 500 laser system, and these are done from systematic reviews, and many of us would consider systematic reviews to be the highest level of evidence when we're looking at the literature. And what you can see is there's a bit of a variation in the results as you expect when you look at cumulative studies. And you can summarize this basically down in the fact that the literature shows that there's basically a variation in results. And this is related to centration and torsional control. Not everybody does markings, as we heard this morning as well. And of course, this is going to affect the outcome or induction of basically aberrations. But basically, SMILE told us many things that with the Visumax 500 laser system. We learned about ocular surface rehabilitation, of course, basically there's no flap. We learned about the improvements based on biomechanics, and of course we learned about stability. And this is vitally important when we're looking about doing lenticular extraction procedures in Asia. A lot of our patients have moderate to high degrees of myopia as opposed to other jurisdictions around the world as well. And this is vital that we look at long-term stability. Now, as Dan mentioned, there are many sort of second-generation procedures now, or KX procedures around the market. This editorial that I wrote in JCRS, published last year in April, talks about basically the second-generation procedures and what we learned basically from the first-generation procedures and what we want to basically improve upon them basically going forward. And of course, the success of any surgical procedure, not just refractive surgery, but any surgical procedure, will always be dependent on the reproducibility of outcomes among multiple surgeons of varying standards. And that's why 2 incisions are useful as opposed to 1 incision, because very experienced surgeons will get around that point of basically doing 1 incision. You have to look at the wider community. We are only, as refractive surgeons, we're only treating the tip of the iceberg of basically the number of patients that need to have refractive surgery. If you want to basically get more patients to have this procedure, we have to look at the wider community. There's no point just keeping it to a few surgeons that have basically excellent results. Of course, in addition to this, I talk about centration, torsion control, obviously in extended range, and I'll talk a little bit about hyperopia in a minute as well. This is basically important. Reducing the risk of suction loss, and I talk a little bit about in the article about how it's possible to do a topography guided treatment as well. So let's just look at some of these with the Visumax basically 800 system. Well, the first thing is basically there's a smaller footprint. You look at the size of the laser on the left-hand side, you've got the Visumax basically 500. If you look at the footprint standalone, this is without the X-line laser, you see it's about 3.8 by 4.4 meters. If you look at the Visumax 800 on the left-hand side over here, you can see it's significantly smaller. Not only that, you'll see at the front over there are wheels on the laser itself, so it can be wheeled out of basically side as well. Then you can say, okay, so what? What's the issue with basically the size of the laser? Well, real estate size is expensive. Okay, if you have a clinic basically in central London or in other parts of the world, you look at basically Seoul here as well, the cost of basically space is a lot. So likewise, you can have basically a smaller space, you can basically have bigger room for patient consultation and basically diagnostics. If you look at this in another way, about looking at the number of people per thousand in these many countries, you can see some of the most populous countries around the world have less space. And you can imagine if you have a much larger laser system there itself, of course there's less space basically for your clinic basically functioning as well. So it's important basically the space requirements when you're basically considering any sort of laser system as well. And also the mobility of the laser, I think, is basically a big advantage. Second point I mentioned to talk about was we mentioned earlier about the speed of the laser system. So here you can see 3 different simulations done with the 500, the same refractive treatment, the 800 on the left-hand side, and the 200 kHz laser, which we still have in our animal facility on the left-hand side itself. You can see how really much faster the 800 laser is with the 2 MHz processor on the laser system. We finished the lenticular procedure, 500 is just finished now, and the 200 is basically still going on in itself. And there's a significant advantage, basically, obviously, to get that. So what are the key advantages to really having the faster laser? And really there's 5. There's less, obviously, risk of suction loss. There's better lenticle customization, which I'll talk about in the next couple of slides. Obviously, better patient experience. If you have a nervous patient undergoing treatment, improvement in basically workflow because it's obviously faster itself, and of course this allows you to do the extended treatment range with basically the hyperopia treatment that's available. When I talk about lenticle customization, all of these variables on the left-hand side allow you to basically customize the lenticle itself, and this is in addition to what you will do with your nomogram adjustment and basically your energy optimization. Dan showed this nice publication from Walter's basically book that we also basically contributed, the effect of basically the SMILE optical zone with respect to spherical aberration reduction itself. And you can see on the left-hand side over here, the larger the optical zone, the more basically tolerance there is to basically decentration. Now, of course, if you're creating a larger optical zone and your laser is basically going slower, it's going to take longer to create that because of the speed of the 500, it allows you to basically do large optical zones because they are basically created quickly as well, and that will then subsequently allow allow you to have less risk of induction of spherical aberration. So this is where you can think about customizing this and varying the optical zone size for the individual patients quite basically safely. When you think about extended range and you look at the market share between myopia, myopia astigmatism and hyperopia, of course hyperopes do constitute a considerable amount of patients that need refractory surgical treatment. So if your laser system can only do myopia or astigmatism, there's a whole chunk of basically patients that basically need to have treatment that are not basically getting that. And we know that basically with lenticle extraction procedures, there's two ways of basically doing a hyperopic treatment. One is what we call subtractive, where we basically use a hyperopic lenticle profile, and of course the multi-center study that was done in Europe showed the safety of this, and this is now commercially available on the Visumax 800, or basically doing lenticle implantation, but that requires a lot more basically certification for use. Centration and cyclotorsion, we talked a lot, and of course the impact of basically decentration ablation is far more than basically a mouse cyclotorsion ablation. You can see this in the ablation profiles in the middle, where you have a laser ablation profile that's been rotated 50 degrees counterclockwise. It almost looks the same, except where you look around the edges, and a descended one below where you see a complete blur of the vision itself. And of course in higher cell treatments, this becomes basically more of an important area. We know from single surgeon studies, so again, if you're looking at single surgeon studies, it is possible. In our contralateral eye study here that we published almost 6 years ago, compared to LASIK, you can match basically the LASIK centration compared to basically that was achievable with the Visumax 500. In this study, we do mark the eyes basically beforehand with a 3-point marking system to allow to basically include the centration. But when you look to a more population-based study, this is the Buchanan Dan study, you can see there's a much wider range of effect itself. So again, single surgeons can compete to what you can get basically with trackers from LASIK, but when you look at a much more population, a larger surgeon base, it becomes much more difficult to basically do that. And that's why basically having a centration control system, like you can see it on the left-hand side, and basically off the eye system on the left-hand side, on the right-hand side, to basically do the torsion control, that can be quite useful. You can see on the left-hand side, especially in barren IODs, you have to use the infrared to basically get the cyclotorsion, get the central system to basically work. But it normally basically allows you to accurately place the lenticle in the right position. And likewise, using the IOL master for the image of the torsion control before the laser. And this has basically been shown to try to basically make the treatment more standardized for more surgeons. And that's really the goal of basically refractive surgery, not to basically cater to one or two surgeons, but to cater to the mass public. That's going to basically increase our numbers. So if you're not doing lenticle extraction, now is really the time to start, especially in the Asia-Pacific region. If you look at the growth rates around the world, the largest, fastest growing region for basic refractive surgery is in basically the Asia-Pacific market as well. So now is the time to basically start to basically take on this wave. As you can see, the market is basically increasing in the future. So I think in conclusion, we've learned many things from the first generation procedure, and I think this has been fantastic, basically learning, but it's really too subjective itself for most of the things that we see in the literature. The 800 allowed you to have a second generation procedure with many of the advantages that I've basically shown you, fully automated control, extended treatment range, less suction loss with a faster laser, better patient experience, and more basically customization itself. I think the majority of the treatments that we're basically ever going to do for refractive surgery, the current technique, basically with second generation techniques, will basically help you. Cognitive guiding requires a lot more thought, basically how we're going to basically do it. It may require docking with a different system to allow you basically to do this itself, but that will require probably a third generation procedure. You can read more about this in this article. Thank you for your attention.
Our next speaker is Sri Ganesh, Dr. Sri Ganesh from India. Sri Ganesh's influence extends globally through his roles on the advisory board of leading ophthalmology company, where he contributes to product development innovation. His unwavering dedication to excellence and patient care continues to inspire and elevate the field of ophthalmology worldwide. It is difficult to choose between visual recovery or ease of surgery. Let's listen from the master what he prefers and how he decides. Please, Doctor.
Thank you. Good afternoon, everybody. And we all know that, as those are financial disclosures, we all know that lenticle extraction is becoming more popular. You have more platforms. Zeiss, almost 12 million plus eyes done, and it's one of the fastest growing procedure in the world today. Is it perfect? It's going there, but then there are a few problems. With Visumax 800, it's so much easier to do smile because you can center well, you don't have to do all those manual calculations and adjustments, you have cyclotorsion, so most of the workflow is automated. We have a training course for smile where we train surgeons who come, and with smile, basically there is a problem that it needs a higher level of skill. So it needs a higher level of skill than LASIK. You need to be able to identify the planes and you need to be able to dissect the tissue. And if you have more difficulty in dissecting the tissue, then again it can result in delayed visual recovery. You can have retained lenticules which are a very specific complication of lenticular extraction. You can have prone lenticules again if you have difficult dissection. So the holy grail is to have an easy dissection. But then again, we know that reducing the energy is much better. If you reduce the energy, then you have better day one results. If you increase the energy, then the day one results are not so good. So now it is a choice whether you want easy dissection or better day one results. So we did this study to look at whether we could get the best of both worlds. So this was a prospective interventional single center study, and still we are towards the end of the recruitment, so I don't have a lot of the results, but I'll just explain what we're doing. 30 patients, 60 eyes undergoing simultaneous bilateral smile procedure with the Visumax 800 were included in the study. The objectives were to evaluate various spot spacing parameters to allow for easier and effortless lenticule extraction with a no dissection technique. Lenticospaces, I described this technique and it was published in 2017 in the GRS, where without any dissection you can go in with the forceps and remove the lenticule. But again, to do this, you need your energies to be optimized and a higher degree of skill. So optimizing the energies are very important to do this technique. So that's why we selected this technique to see whether we could do this and optimize the energies. Now Visumax is the only system where you can probably adjust the spot spacing and vary it and play around with it, and that's what we decided to do. The secondary endpoint was day one visual, uncorrected visual acuity and the OSI, because the OSI, the objective scatter index, measured with the HD analyzer, gives you the quality of the interface. So if the interface is not good, you have more scatter. So patients may have 20/20 vision on day one, but if the scatter is high and the contrast is poor, the quality of vision is not good and they are unhappy. They are 20/20 unhappy, and you don't want such patients. You want that wow factor on day one, like LASIK, where they go around and tell everyone that, oh, it's great. Like Dan was speaking, that's why we need the OSI solution. So we included patients between 21 to 40 years with myopia and myopic acid between 2 and 10 diopters and cylinder within 5 diopters. Of course, the usual exclusion criteria for smile. And we did all the pre-op tests, the uncorrected, best-corrected vision using ETDRS charts, subjective refraction, topography, IOMaster, iTrace, HD analyzer for the objective scatter index. So you have the standard settings most of us are using. In our center, the standard settings, we have a cut spot separation of 4.5 microns, and for the lenticule, spot separation of 4.3 microns, and a track distance of 4.5 microns. And right now, our laser is at an energy index of 27. It varies again. Previously, we were using an energy index of about 24. Then we changed the cavity, and then now it's 27, so it varies from machine to machine. Then these were the various settings with which we experimented, from 3.5 micron spot separation, went down to 3.3 microns, 2.8, 2.5, 2.2, and even 1 micron. Now the newer settings which we are kind of experimenting is much lower. See, this is the optimized settings which we finally arrived at cap cut separation of 1 micron, lenticule cut separation, spots separation of 1 micron, and a track distance of 2 microns, with a very low energy index, 20. That means it's 100 nanojoules, which is again very low. These settings are not available commercially on our machines, so once we are done with the study, probably Zeiss may offer it for easier dissection. Use a standard cap thickness of 110 or 120 microns, optical zone of 6 to 7 millimeters, and minimum thickness of lenticule 10 to 20 microns, depending on the refractive. So, what were the parameters that were evaluated? Time taken for laser delivery, severity of the OBL, which was rated as less than 25, less than 50, less than 75, less than 100. Ease of lenticule extraction using the lenticular technique on a grade of 1 to 5, 1 being effortless, almost a free-floating lenticule, and 5 being very difficult or inseparable. And also the number of times we were able to easily remove the lenticular or we had to convert a conventional dissection. So I'll show you the standard technique. This is the first case, 28-year female, both as micro, energy index 27. Like I said, cap cut spot separation is 4.5 microns, lenticule cut 4.3, track distance 4.5 microns, and you can see the post-op day 1 visual acuity was 6.5 parts and N6. The OSIs here were, I will show you the video. So you can see this takes just about 8 seconds, and there is no OBL. The bubble pattern is almost perfect. It's optimized for the dissection, and that's the Reinstein dissector which I am using. Find the 2 planes, and then you can see that dissection there is some amount of resistance, but this is like the standard technique. We dissect the cap cut and then the lenticule cut, leave a tissue bridge, go across to the other side. And then just extract the lenticule. Now with this, the results are pretty standard, and if you look at the day 1 OSIs, I'm sorry, I think the slides are got mixed up here. The OSI slides. Okay. The OSIs were within 1. Let me quickly go, I think. Yeah. These were the OSIs, 0.9 in the right eye and 0.6 in the left eye. So this, you can see that ideally an OSI of 1.5 is better. Less than 1.5 is normal, very low scatter, and then you can see the NPF also is, the point spread function is good. Now this is with the standard dissection. You have 20/20 or better and a very happy patient, but only thing, the dissection is difficult. So when you're starting out with SMILE, it's very important that you are comfortable with the procedure, you are able to dissect the lenticule very easily, and you don't have any complications. So then we have the optimized settings for easy dissection. Here we are using this is a 25-year-old female where we did SMILE Pro. Energy index is just 20, which is again low. Cap cut spot separation is 1 micron, lenticule cut spot separation is 1 micron, and the track distance is 2 microns. Day 1 vision is good, uncorrected both as 6.5 and N5, and we can see this is the pattern. If you look at the laser takes a longer duration, about 22 seconds, and you can see that there is no OBL here or black spots, but the pattern is a little different. But the dissection is very easy. This is lenticular slices, the no dissection technique. I just go into the forceps, open the jaws, hold the lenticule, push down, and then you can just pull out the lenticule. So it's actually very easy to remove the lenticule. Even the dissection is very easy. It's just like grade 1.5 or 2, hardly any resistance. So it's very easy to remove. And now these are the settings we use to train beginners, because for them, when it's easy to dissect the lenticule, they get a lot of confidence. And if you look at the OSIs, in this case, it was the right eye 1.7, left eye 1.8. So it's higher than 1.5. It takes about a week or so for the scatter to improve and for the MPF to improve. But then the advantage is that the dissection is very easy. It's very easy to do, and it is, for beginner surgeons, it's very comfortable. So that's the reason we kind of propose that it's ideal to have 2 parameters. Parameter 1, when you're starting off learning smile, you have very easy dissection, fairly good quality of vision on day 1, but the OSI takes about 2 to 3 weeks to recover. Again, the risk of complications like retained lenticule or lenticule tear is almost nil. And then once you have done a few cases, you're very comfortable with the technique, then you can use the more advanced parameters, which has a little more difficulty in dissection, and it needs a little higher level of skill. But you have great visual acuity on day 1 and faster recovery of the OSIs. So that was our study. We are still doing the study. I've still got to compile all the parameters and the results from all the parameters, but this is just a preview into what we are doing and how we have found a kind of a balance of getting fairly good visual acuity with a very easy dissection, especially for beginners. Thank you very much for your attention.
Our final speaker, next speaker is Dr. Eng from Singapore. Dr. Eng is a leading ophthalmologist in Singapore, renowned for his expertise in corneal and refractive surgery, as well as his dedication to advancing eye care through research, education, and humanitarian efforts. He is deeply committed to humanitarian work, providing free eye care and cataract surgeries in underserved regions across Asia. Dr. Eng's contribution underscores his commitment to improving vision and accessibility both in Singapore and internationally. The most powerful marketing tool is word of mouth despite too many current platforms. Let's hear how patient experience is better with Smile Pro and justified investment. Thank you, Dr.
Thank you very much. So I had the honor of having the last word in this session, which was great. I think we talked a lot about the technical aspects of Smile, Smile Pro, and how the technology has really advanced and helped us as surgeons achieve better outcomes. So I thought we would switch gears a little bit and talk about from the patient's perspective. And I think the first speaker actually mentioned a little bit about this topic, but I wanted to share some of the experiences that we've had. I do have 2 quick announcements. I am given 9 minutes to finish this talk. And the press bio session, which Dan and I are going to be in, is in the rules room. And because we're slightly late, after my last talk, we'll head over there in about 5 minutes. So, these are my financial disclosures. So I think KLX has really changed the way we view laser therapy refractive surgery, and I think a lot of speakers have already, before me, have spoken about what great results we're getting from LASIK and now from Smile and Smile Pro. But can we do better? In fact, I went to visit one of the refractive centers in Seoul, and they were sharing with me that actually one of the largest chat rooms in Korea, in Seoul, is actually dominated by LASIK patients. So what they do is that there are 250,000 of these patients on the chat room, both pre and post surgery, and what they do is that they share their patient experience and they recommend surgeons, and the surgeons go on as well. So you can see word of mouth is really key in refractive surgery. I won't spend too long on this because previous speakers have already spoke about it, but essentially refractive lens extraction has really changed the way we practice, and now the advantages of Smile and Smile Pro are really that we have a flapless procedure with multiple advantages. Dan talked about this, and this is really one of the unique points of the Visumax system, both in 500 and 800, and this means that the patient had actually may have a better or less discomfort during the femtosecond laser. And now, of course, with the 800, with this increased speed, I'll talk about this later, this advantage becomes even more pronounced. So when we ask patients about their experience after SMILE, it could be very, very subjective, as we all know, and you could divide them broadly into intraoperative experience as well as post-operative symptoms. So, for example, visual disability at night, glare, as well as reducing contrast sensitivity. But actually what we really need is questionnaires or tools for us to measure these subjective symptoms. And actually there aren't that many accurate or validated questionnaires out there. We published this before looking at QRC, which is basically a questionnaire for refractive surgery. And what we found was that a lot of publications, a lot of groups that used to study this really lump or group the symptoms and the scores together. And what we found was that that's not really useful. We actually need to divide them into what we call the functional aspects and the emotional aspects. So you can see, for example, in this small study that we did, as visual recovery occurs, patients who underwent LASIK actually recovered their visual function sooner than SMILE. There are longer-term studies that look at this as well. And again, just to highlight that these questionnaires really require a lot more analysis and detailed analysis into the different parts before we can actually interpret the results. Now we conducted a very unique randomized trial at SNEC, led by John, and basically this allowed us to, of course, look at not just clinical outcomes, but because of the unique fellow eye study design, we were able to really extensively look at intraoperative and post-operative symptoms experienced by the patients because they're having SMILE in one eye and femtosecond LASIK in the other eye. And of course, this was published a long time ago, and I won't spend too long talking about the clinical results, which were essentially comparable between the LASIK and SMILE eye. But I just wanted to spend a little bit more time about the intraoperative experience. So remember, the patients were having LASIK in one eye and SMILE in the other eye, and at that time, back in those days, patients weren't as aware about the differences, so they were masked to the procedure. So what you can see is that, apart from discomfort and feelings during the vacuum suction, actually, most of the patients felt a little bit more uncomfortable during the surgical manipulation of the lenticular dissection. And I'll come back to this later on when I'm talking about SMILE Pro. And what we also found was that suction loss during the surgery really made a big difference to the intraoperative experience. In other words, when patients, and this is not surprising, right? When patients experience suction loss, their experience goes down a lot. You have to redock or try and redock again, or even abort the procedure. So patients who had suction loss really reported a poor intraoperative experience, and of course we know this with the Visumax 500 as part of our learning curve, and even in the most experienced surgeon's hands, suction loss can happen still and can happen at any time. So there's some videos showing that it can happen early or late, and of course I won't spend too long about talking about how we can view this suction loss, but really from the patient's perspective, if they're already nervous, this is going to affect their outcomes. Now, what about symptoms? I mean, when we were back to the randomized trial again, I mean, we could look at the symptoms experienced by the patient in this very unique fellow eye study, and of course you can see that as the vision recovers, patients who had LASIK had less symptoms at 1 month compared to the SMILE eye, but at 3 months as the vision stabilized, actually there was no difference between both eyes. So what we're doing next is really looking at, in the future, is looking at vision-related quality of life outcomes, comparing LASIK, SMILE, and of course many other combinations of these procedures. I won't spend too long explaining, but essentially I think we need more and more of these kinds of studies to look at the quality of life, the impact on quality of life of SMILE patients. So for those of us who are moving from 500 to 800 platform, I think the first speaker spoke about this already. It's really a different patient experience. If any of you have gone under the machine, the 500 is basically a bit that goes under, and the 800 is more open and apparently less claustrophobic experience for some patients. Having said that, when I interviewed some of my 800 patients, they actually found that the laser head coming down was actually quite scary as well. So I usually get my patients to close their eyes. I won't spend too long again on this, the procedure itself. I think wanted to highlight 3 key advantages of moving from Smile to Smile Pro on the Visumax 800 system that really changes the patient experience. The first one, of course, is speed. I mean, this is obviously this is very obvious, and I think the patients often comment just after the 800 that how quick the femtosecond laser cut was, and of course the comfort is still the same or similar to the 500. Centration, because it really helps to improve the outcomes of the patient, but also it's, I think that happened really too quickly. It's really quick and intuitive. So actually there's not much delay in the docking as well as the alignment before you actually do the femtosecond laser cuts. And last but not least, of course, is cycle torsion. So now all the patients have their registration done, and we no longer need to mark the eye, spend a long time touching the eye before we do the vertical extraction. So in summary, I think Smile Pro has now given us the opportunity to give our patients an even better patient experience. And back to my point on suction loss, I think the first 100 eyes, or these are just my early results from my Smile Pro. My first 100 Smile Pro eyes, I had no cases of suction loss. And as we mentioned earlier in our previous study, we found that suction loss really degrades patient experience. So I think this is definitely one of the advantages. And here's a very quick pilot study that we did using that same questionnaire that we did in our randomized trial, looking at Smile Pro, and actually quite interestingly, the patients scored better in terms of the feelings of the vacuum or feeling frightened about the vacuum procedures. So they're actually a lot more comfortable. And remember, I mentioned that in the randomized trial, the patients who were undergoing Smile actually felt a little bit more uncomfortable during the lenticular dissection, and you can see that actually in the Smile Pro patients, somehow they are actually rating the experience to be very close to what our LASIK patients were experiencing. So I think this is something to look forward to. We're still collecting more data on intraoperative experience, but I think that with the advances in the technology, now patients hopefully will feel more comfortable during the procedure, have less incidents of suction loss, and less complications or aborting the procedure, and of course our post-operative outcomes, if they are much better, are going to lead to better patient satisfaction as well. So I'd like to acknowledge my team in SNC in Siri, and I thank you very much. I finished on time already. Do you guys?
That was really good. Thank you to everybody. I think we are running out of time. Is that right, Nadi? Are we taking any questions? No. So thank you, everybody. Thank you very much for attending this insightful session from everybody. Thank you.
And so quickly to end this session, really talking about patient expectations and outcomes. But nowadays, I think it's really expectations that we're trying to meet. Now we have 10 minutes. We are slightly over, and I'd like to also then call on Professor Cho and Professor Ryu to also help us with the discussion. We've got now the Slido QR code, so you can ask questions by posting them on Slido, or there are microphones on the floor. Please come up and indicate that you've got a question, and we'll come to you. Professor Cho and Professor Lee.
Yeah, I'm an enterosegment surgeon in cataract. I have a question for Dr. Reinstein. You have an outlier on the very hot, humid day, so you don't have any control systems on your sleep. When you have the outlier on your result, on the Smile result, you said that day the very humid of the campus, very humid. You said that, maybe I get wrong.
I'm not exactly, I think I know what you're asking. How do I know something is an outlier and not just an actual result that I should incorporate into the calculation? Right? I think that's what you mean. Well, part of it is a case like that where the cylinder is so undercorrected. That's not normal. And so when you're trying to, a nomogram is a way of determining the average response. And so, for example, if, let's say, the average weight of the people in this audience, you know, men and women with different weights, but let's say the average weight in this room is 63 kilos, average. Now, if suddenly a couple of Americans walk in from Arkansas, and they've just been shopping at Walmart, and they can't walk because they weigh too much, so they give them these little electric carts, and they go down the aisle in their little, and they buy potato chips, chocolate, ice cream, insulin, because you can buy everything in Walmart. Use a big screen because they have no macula, so they need a big screen, a television. If 3 of those people, or 5 of those people suddenly decide to come to this meeting, and we do the average weight, and they each weigh 400 pounds, that's actually going to change the opinion of the average weight. So we're more interested in the median weight, for example, or some other way of determining the average response. And I mean, that's actually what we're doing, is we're trying to make sure that when we're trying to determine the average response, we're not skewed by points that are really not part of the equation. For example, when we do a multivariate regression analysis model where we include, you know, cylinder squared times sphere, or age times, you know, pupil size, or all these other mixed terms, sometimes in the analysis they are statistically significant. But if you look at the level of significance, it might be low, it might be 0.049. And you don't want to include that in your nomogram because that could just be a 1 in 20 chance that that point is there. You don't want to, you know, affect the whole population based on something that doesn't have a lot of significance. So it's a statistical process, and there is software that can determine outliers for you. But here, I'm showing a manual process of just saying, well, that definitely is wrong, out of the analysis.
Thank you. We've got some questions on Slido as well. Let's take the first one, maybe to Anita. Sumita. Can you just take that first one? Use Forum with a non-size instrument such as Pentacam?
Yeah, we can just create a PDF file of the Pentacam images, whatever you want, and you can export it to Forum. It's non-size thing, but I do it quite often.
Thank you. Harvey? The retina workflow, selecting the last 3 visits, can we manually select other visits for the analysis?
Yeah, so with the retina workflow, the default is to show you the first visit of the patient to your practice, and then the last 2. But it allows you to select the OCT image from any of the visits, and you basically just drag and drop into the screen, and you can see any visit in any combination that you want.
Yep. And you can also set it as a baseline band.
So you skip it there.
I was going to come to you.
Yeah, this is a very interesting question. So, you know, do I use the nomogram for every eye or? Well, yes, of course I do. The more data, the more confident your response is. And how we get multivariate analysis is by having big data. So we have 60,000 eyes treated with all the different procedures with 1-year follow-up over the last 24 years. So our nomograms are exceeding, it is the best we can do. They just can't do better than that. But not everybody can do that. And so the answer is, when do you stop? Well, it's up to you. You know, some people can do a nomogram setting and just keep using it. And then if you start to find that you're getting overcorrections for some reason, then, well, you need to investigate. Maybe your calibration paper is a bad batch. Maybe the optometrist is depressed because he's getting divorced and he's not spending as much time pushing plus. You just don't know what the factors are, right? So you need to continuously monitor your outcomes. In London Vision Clinic, we actually continuously monitor things. And let me give you an example of how this worked for us in marketing and in introducing new surgeons. When I started my practice by myself with 4 people, creating freedom 4 people. And I had my first fellow. My first fellow was Glenn Karp from South Africa. And he did his first 200 eyes in the clinic after 1 year of training, not touching any eyes. And his first 200 eyes were on the Visumax, making flap. My first 200 eyes on the Visumax were also at the same time because we got the Visumax in 2007. But I had already done 16,000 flaps with the Nidec, my Paratone, the LSK1, and mostly the Hansatone. So I had a lot of experience, but not with the Visumax. And neither did he, but he didn't have the experience. And this is what shows you that we published 2 papers on this. The first paper was showing that his outcomes, his first 200 eyes, he got the same outcomes as an expert operating on a new machine also. We were to prove that. And the second paper was an analysis of the videos. And we have something called a surgical optimizer at Zeiss. And this allows you to compare the way that you've operated with an expert. And it's a way of privately getting a slap on the face when you realize that you're not doing something very efficiently instead of having someone in the room making you embarrassed. But you see, the second paper, we were timing the different steps of the procedure. And we showed that my timings were exactly the same as his timings. And so 16,000 eyes versus 200 is the same. Now how does that help? It means that when someone calls the clinic and says, oh no, I want Professor Reinstein, and then the staff says, no problem, you can wait 3 months. And they go, but I'm going on vacation next week. Well, we have Dr. Karp. Well, who the hell is Dr. Karp? Well, he gets the same results as Professor Reinstein. Here's the Journal of Refractive Surgery publication. They're identical. Oh, and he's younger, and he's nicer. And so, okay, so do you understand? Everything in refractive surgery, you guys are going to have to excuse us, but we always have to tie the commercial, business, marketing, and sales aspect to the science. And it sounds a little bit crass, but that's the way we deal with things.
Thanks, Ed. Professor Lee?
I have a quick question to Professor Smita. So you're saying we can use workplace for cataract surgery before cataract surgery and during the cataract surgery, but I think we can use also this workplace after cataract surgery. I mean the post-op management, because I have been using this workplace to create my own optimized A constant. So could you share your thought about using the workplace after cataract surgery?
We can definitely use workplace after cataract surgery. Once you have the whole setup, size, Cutera machine, if you're operating, then all the data can be incorporated and entered post-op results, and then you can optimize your results based on what you attempted and what results you got, and you can use that nomogram as you get further after the
A constant is the nomogram for cataract surgery. And of course the A constant is the substitute for the fact that we don't know the effective lens position, which is ELP, which is the elephant in the room about IOL calculations. And no one solved that yet. The last question is, it follows from what I was saying. Absolutely. So you see, in our center, we published a paper, you won't believe this, we published the first paper in the history of refractive surgery on the inter-observer repeatability of refraction in a refractive surgery setting. There had been 50 million procedures performed in the world, but no one had shown that 2 people refracting the same patient, how close are the refractions? Now, our inter-observer repeatability
between 7 optometrists and 2 surgeons was 0.19 diopters. It was better than the resolution of a 4-opter. Now that's because we have standardization. And so the question here is, do we have different nomograms for different surgeons? In our clinic, myself, Glenn, and Darshak Patel, who started with us 2 years ago, we all use the same nomogram. Why is that? Because our refraction technique is exactly the same, our surgical timing and techniques are exactly the same, and we analyze it every year, but we never find differences. However, if you work in a center with, I don't know, 10 surgeons showing up with their patients, different, they come with their own data and their refraction, absolutely, you can use Visumax to individualize the outcomes for that surgeon.
Smita, the last comment from you.
Dan, that was a great talk. Unfortunately, not all of us have the luxury of having 60,000 patients. What is the minimum number that you need to help create a nomogram on Visumax? Second question, do we need different nomograms for hyperopic smile and myopic smile?
Okay, the minimum number of eyes is 1. Well, my first smile procedure, was a patient that I treated -10 in one eye only. Okay, this was 2011. Okay, this is really early. I had no idea what was going to happen here. So she was -10. I put -10 in the laser. Day 1, she was -1. Now that tells me that probably she's going to finish -150, because I understand, wound healing. What did I do with the next eye, the next day? I entered, for -10, I entered -1125. The next day, I didn't wait for 50 eyes. Like, this thing's undercorrecting. Now, the nomogram was set with other surgeons who had done some other early work before I thought a smile was going to work, and I wasn't doing it. You know this, right? I was against smile for a long time. But they over-minus, or they don't take care of the vertexes while they're refracting. I don't know why, but they had more myopia in the same patient than I would have had. So for them, it worked well. So the minimum is 1. The ideal is that you start with your new device, and you start entering the data every day, and you do spherical refractions on day 1 and 1 week and 1 month. Not this cylinder, because that can change over time, but you do a spherical equivalent refraction, and you enter that as you go. And so the beautiful thing about having an internal software is that you just enter the data and recalculate. And as you recalculate, it will refine the behavior of that nomogram. In our clinic, we do a yearly. Now, we're so stable that we only do the nomograms once a year. And it's beautiful to see, here are the results, same, everyone's the same, can't improve on it, nomograms are set, slope is 1, R squared is very high, we're happy in that way. So that's the thing, you see, you have to use a little bit of common sense, not just, statistical power calculations, yeah.
Okay, I'm afraid we have to close. We are running over time. So thank you all to the panelists and speakers. Wonderful session. We have 10 minutes for a short break. Please return for the next session. Thank you very much.